Thank you very much. Dear Chairman, dear colleagues, I would like to thank the organizing committee for the invitation. And for me, it's a very pleasure to represent Russian Society of Cardiology and Russian Society of Endovascular Surgeons, and also Siberian Association of Interventional Cardiologists. My topic is devoted to revascularization concept in patients with non-ST segment elevation in acute coronary syndrome from PCI to emergency coronary artery bypass grafting and PCI with ECMO support. The first, I would like to demonstrate you the general situation in Russian Federation according number of percutaneous coronary intervention last 10 years. As you can see, number of PCIs increased by 2.5 times. What about acute coronary syndrome PCIs? Numbers of PCIs in acute coronary syndrome for 10 years increased by 3.2 times. This is the ratio of PCI to coronary artery bypass grafting in the Russian Federation. Now it is about 10 to 1. My clinical case is devoted to patient, male, 77 years old, high-risk non-ST segment elevation acute coronary syndrome, KILIP-1, myocardial infarction in past, left ventricular ejection fraction 46. The patient was immediately underwent angio. As you can see, left dominant, multi-vessel complex coronary artery disease with heart calcification, left main disease, LAD stenosis, circ stenosis, and right coronary artery stenosis. This is our heart team decision, refusal of PCI due to heart coronary lesions, unprotected left main, calcification, refusal of KBH due to porcelain aorta and loaded with antiplatelet agents. We know that if we use conservative treatment, hospital mortality rate will about 30%. And our heart team decision, PCI plus mechanical circulatory support, vena arterial ECMO. What about indications to PCI plus ECMO support? Here you can see clinical expert consensus statement of the use of percutaneous mechanical circulatory support devices. And the main factors for using mechanical circulatory support are complex coronary lesions, low ejection fraction, and technically challenging PCI. This is our algorithm which we use in our clinic. We need to presence of two of the following three factors: technically challenging PCI procedure, large volume of myocardium but target arteries based on Jeopardy score, and low global contractility of left ventricle. Here you can see current classification of cardiogenic shock stage, and we can say that high-risk non-ST segment elevation acute coronary syndrome patients may be classified as stage A, high risk of development of cardiogenic shock. This is our PCI results. We use vena arterial ECMO support. We implanted 4 stents. We used 10 balloon catheters, 200 milliliters of contrast medium. The base stage of PCI took about 3 hours. Blood loss was 600 milliliters. We used ProGlide and Angiosil for hemostasis. Patient went from ECMO in cath lab, extubated after 12 hours after PCI, transferred to the cardiology department from the intensive care unit after 36 hours, and in 10 days discharged from the hospital. Here you can see the final angio result in left coronary artery. This is important practical questions. We need to have standby church ECMO device. We need to use arterial ultrasound. We need 24/7 vascular surgery support. We need to use ProGlide and Angiosil for hemostasis, and we need to have the second cath lab to do revascularization for another acute coronary syndrome patients. This is our self-study design. We compared the results of revascularization using emergency KBH, emergency PCI, and a small pilot study, we compared emergency CABG and emergency PCI plus ECMO support. This is general 2 years result when we compared CABG and standard PCI. As you can see, CABG better than PCI according MACE. We believe that this is due to higher potential of CABG for achieving complete revascularization and using LIMA as a graft to LAD. When we compared the results of CABG and PCI plus ECMO support during 2 years, we can see also better results of CABG group. We believe that this is due to low comorbidity of CABG patients. But another side, taking into account initial comorbidity status and low ejection fraction for PCI plus ECMO group, this survival and MACE quite satisfactory. And this is my conclusions. Each center working with patients with acute coronary syndrome should have the ability to implement 3 main revascularization strategies: PCI, emergency CABG, and PCI plus ECMO support. Thank you very much for your attention.